Just 1 minute. Ma'am, it's visible?
Yes, you're visible and audible, Pramod. It's not in the full screen mode yet, though.
Okay, ma'am. Is okay, ma'am?
Not full screen yet. Your slides are visible, but it's not
Yes.
in a full screen mode as of now.
I started my slides, so ma'am.
एक बारी get out of it and try again. Otherwise,
Yes, ma'am. So now it's okay, ma'am?
we can see your screen, but not yet in the full screen mode. I think it's okay if you're not able to do this full screen mode. Just start like that.
Okay, ma'am. Okay. So, good evening to all. Very nice introduction by the Richa ma'am. Thank you, ma'am. So today topic of my presentation is preparation and administration of chemotherapy. So for the nursing point of view, it's a very important topic. And in our day-to-day activities, we daily prepare and administer the chemotherapy. So I'm nothing to tell new to you, but it's just a kind of just revise the topic. So first, I would like to define the cancer. The cancer is a disease of abnormal cell growth and uncontrolled division. All of you know about the cancer, what is the cancer and how it occur. So I'm not going to detail. Sure, ma'am.
Pramod, your slide is not moving. Are you moving your slides?
Yes, ma'am.
Can you just go out of the full screen mode and try to move your slide?
Yes.
बोलो ना फिलहाल तो कुछ नहीं
Just stay in this mode without going into full screen and share your slides like this and try to move them. Yes, they're moving now.
Sure, ma'am. Sure, not issue.
ऐसे आप ऐसे ही कर लो present.
Yes, ma'am. Yes, ma'am. So how common is the cancer in the children? So this map shows the distribution of childhood cancer cases around the world. Around 5% of the all cancer compromise in children, and over 4 lakh children diagnosed around the world each year about to cancer. And unfortunately, 90% of these children living in the low and middle income countries. So it's a very alarming situation in the for the low and middle income countries. Cancer treatment modalities available for the children, including the surgery, radiation therapy, chemotherapy, targeted therapy, and stem cell transplant. So here we discuss about the chemotherapy and what is the how to prepare the chemotherapy and how to administer chemotherapy. So firstly, we define the hazardous drugs. So it is important to define the hazardous drugs because in day-to-day activities, we prepare and we administer hazardous drugs. So how we define the hazardous drugs? So first is a definition given by the NIOS, National Institute of the Safety, Health and given by the NIOS 2016. And if the any drugs meets one of the criteria is known as the hazardous drugs and dealing and preparation as per the NIOS guideline. So drugs, if any drugs exhibits the carcinogenicity, may cause the cancer. Teratogenicity can alter the development of an embryo or fetus, or reproductive toxicity may interfere with the normal reproduction or fertility. Organ toxicity alone may cause damage to the organ or organ function, or genotoxicity means may cause a mutation in the gene. So if any drugs meet one criteria, then it considered as a hazardous drugs and management and the kind of administration as per the NIOS guideline. So some example of the hazardous drugs in the antineoplastic, we daily use the gemcitabine, cisplatin, cyclophosphamide, vincristine, mitogenton. In the non-antineoplastic, cyclosporin, reproductive carvedil. So studies have shown that there is evidence of health risk and that no safe level of exposure to the cytotoxic agent. Means if we prepare the cytotoxic medication, so there is no safe level. Means in each and every step we should take care of ourselves as well as the patient. Healthcare workers who handle the hazardous drugs are likely exposed to multiple agents on any given day, and no reliable method for monitoring work-related exposure exists, especially in the developing countries. Therefore, it is imperative that those who work with the hazardous drugs adhere to practice designed to minimize occupational exposure. In the next slide, we chemotherapy. So what is the chemotherapy? Chemotherapy basically the medication that works by killing rapidly dividing cells, is a cancer cell, can be given by the orally, injectable, subcutaneous, or spinal fluid, especially methotrexate and the cytarabine. So this is the classification of the anti-cancer medicine. All of you know about the classification. So broadly, medicine divided into alkylating, antimetabolite, antibiotics, taxans, and vinalkaloids, and the others. So this is the basic. In pediatric setting, we mostly use the cyclophosphamide, ifosfamide, cisplatin, carboplatin, dactynomycin, doxorubicin, bleomycin, and the vincristine and blastine and rolobine. So these medicine mostly used in the pediatric settings. This is the actual picture of the medicine we mostly use in the pediatric settings. All of you know about it. So why hazardous drugs management is so important? There is basically the three main reasons to manage the hazardous drugs. First, protect yourself, means healthcare worker who directly or indirectly involved in the management and preparation and administration of the hazardous drugs are safe. So hazardous drugs management is important. Protection of the patient. It is our duty to protect the patient and as well as the environment. So potential adverse health effect associated with occupational exposure to antineoplastic agent. In the first, it is observed in the study conducted in the 2003 and the 1992. It is observed that the exposed worker have the greater chance of the occurrence of the cancer as compared to the non-exposed worker. In the chance of the exposed worker is greater at 10.65 relative risk in the acute leukemia as compared to the non-exposed worker, and overall increased occurrence of the cancer among the, especially in the nurses and the pharmacists, as compared to the non-exposed healthcare worker, and odd ratio is the 3.27. In the genotoxicity marker, chromosomal aberration also found in the chromosome 5 and 7 in the exposed worker as compared to the non-exposed worker. Sister chromatid exchange also found in the two studies. Micronuclear changes, HPRT mutation, and chromatase also found in the exposed worker as compared to the non-exposed. HPRT mutation mostly found in the healthcare worker who mostly prepare the methotrexate and the vincristine. In the reproductive outcome, infertility, spontaneous abortion, premature labor, preterm birth, and learning disability in offspring also found in the exposed worker as compared to the non-exposed worker. And these studies mostly conducted in the developed countries, the data from the developed countries, and mostly on the pharmacists and the nurses. And exposure opportunities getting through the skin or mucous membrane, needle stick injury, inhalation, or injection of the some kind of chemotherapy medicine. Pharmacists and nurses exposure during the handling, and 12 to 24% taking home potentially contaminated cloth when the nurses and pharmacists who work in the chemotherapy area are not wearing proper PPE. 11 to 17% dermal or eye exposure during their preparation or administration, and 1.4% sharp injury involving in the chemotherapy preparation and administration. And spill is also found in the nursery. About 12% reported as a spill during the chemotherapy preparation and administration. And most common reason for failure to wear the gown, it is also observed in the Vienna 2014 study. Failure to use chemo-tested gloves, because in the most of the settings, still chemotherapy gloves are not available, or kind of not available in the market. Some kind of simple gloves are wearing during the preparation and administration. Use of closed system transfer devices, CSTD, is not used in our setting, but mostly used in the developed countries. So here, in the hierarchy of hazard control, how to control the hazards, because it's a known effect of the some chemotherapy medication. So how to manage the hazards. So first is the elimination of the hazard is the highest level of hierarchy, but it is not possible in the also setting. Second is the engineering control. In the engineering control, biosafety cabinet and the closed system transfer device. In our setting, we use the biosafety cabinet in our daycare as well as in the ward setting. In the administrative control, safe handling policies, policies are made by the some kind of organization, some HODs. So how to handle the chemotherapy? It is a written protocol in our daycare. Work practice, how to work, and education and training of the staff as well as the resident doctor who directly or indirectly involved in the chemotherapy preparation and administration. And fourth is the personal protective equipment. What personal protective equipment should we wear during the chemotherapy preparation and administration? We will discuss on the next slide. The biosafety cabinet class 2 is used for the chemotherapy preparation. It's a biosafety cabinet is a ventilated cabinet that protect personnel, product, and the work environment. Open front, this is the mainly three part. This is the open, it's a downward, and it's a upward. So open front with inward laminar airflow protect personnel. This one. Downward HEPA filter, laminar airflow protect the product. This one. And the filter exhaust air protect the environment is the upper side. Contaminated air is handled in the cabinet also. So this is the pics of the biosafety cabinet in our daycare. How we use, we will discuss in the next slide about it. So key point for using the biosafety cabinet, always work with the laminar flow on, because when we start the preparation of the cabinet chemotherapy, we just start the laminar flow starting, then we put all the medication or all the necessary item in the biosafety cabinet. Work in the center of the station. All work shall be performed at least 6 inches within the hood, window, and the adjacent wall. All drugs shall be removed from the box before placing in the hood, because it obstructs the airflow. So when we prepare the chemotherapy medication, all the wrappers of the medication should be discarded before, then vial or ampoule should be placed in the biosafety cabinet. No item be placed over the front exhaust grill is obstruct the airflow. Nothing should obstruct on the downstream outlet area. Do not keep scrap or waste in the workplace area. In the closed system drug transfer devices, it is not used in our setting, but it is mandatory. So closed system transfer device mechanically prevent transfer of environmental contamination into the system and exposure of hazardous drugs outside the system. CSTD has sustainably reduced the surface contamination. So it is necessary for the chemotherapy preparation. Closed carts can be used for transportation to prevent the drugs from breakage and contamination. These carts have enough compartment for the different patient medication, sufficient space to accommodate their respective treatment plans. So it's a very useful. So what PPE we should wear and how to wear, we discuss in next one by one. So PPE is designed to protect healthcare worker from exposure to the potentially infectious material. PPE should be used whenever there is a risk for exposure to the chemotherapy. What PPE we should include? Face protection, respirator, N95 mask, eye protection, gloves, gown, and shoe cover and the head cover. The situation requiring PPE, NEOS recommend that gown and gloves be worn for all hazardous drugs handling activities, and that eye, face, and respiratory protection be used when splash or inhalation exposure is possible. In case of intact tablet or oral medication, single pair of chemotherapy tester gloves is sufficient. So this is the slide. What PPE do I need? Means all the PPE we don't need all time full of PPE should be worn. What type of activities we do? Sorry. What PPE do I need? During the labeling, storage, and transportation, single gloves, gown, or respirator, or transported in a leak-proof container should be worn. During the preparation and administration, all set of the PPE should be worn. During the disposal of the biomedical waste of the cytotoxic medication, double gloves, gown, and eye and face protection should be wear. During the handling of the body fluid of the patient who received the chemotherapy, double gloves, gown, and eye face protection should be used. So this is very important for the nursing point of view. We always wear the kind of some full set of PPE. So this is not a requirement for the all time. This is only required for the preparation and the administration. So PPE should be used whenever there is a possibility that cytotoxic agent will be released into the environment. Gloves should be sterile, powder-free, disposable, and chemo-safe. Double gloves are recommended. Wear the inner gloves under the cuff and the outer gloves over the cuff of the gown. Remove and discard gloves immediately after the use. If tear, puncture, or non, discard the old gloves and replace with the new gloves. Gown must be disposable, lint-free, and non-permeable. Must have the solid front and a back with the closure. Must be long-sleeved, have tight-fitting cuff. Gown should be disposed after each use. Do not wear gown outside the compounding area. It will contaminate some non-infected area. Used gowns should not be hung up or reapplied after the removal. It is mostly seen in some public hospital. So this is not a good practice. The respirator, NEOS recommend the N95 mask. Eye goggles and face shield. Use eye and face protection when preparing drug outside the biosafety cabinet or inside the biosafety cabinet, cleaning the biosafety cabinet or the chemotherapy spillage. So always wear the eye goggles or face shield. Using eye goggles or face shield offer full protection in the eye and the face. Shoe cover and sleeves cover, hair cover, and shoe cover should be made using coated material or laminate material. Do not wear shoe cover outside the compounding area to avoid contaminated other area and a possible exposure to the non-protected worker. So this is advisable for the all. How to remove the PPE? First, we remove the outer gloves, then eye protection or eye shield, gown and shoe cover, inner gloves, wash hand, respirator, and the wash hand. So this is a very common practice we saw in the COVID. To dispose of the PPE, all PPE worn when handling hazardous or cytotoxic drug is likely to be contaminated with minimum or trace amount of the drug. So in our daycare setting, what we do, when the 1/3 of the biomedical waste is filled up, we just is label it as a cytotoxic medication, and label is, and through the sanitary attendant, we directly send to the kind of incinerator and burn it. The storage and labeling, place at designated place. Appropriate storage conditions should be there. Distinct label including the patient name, dose, and container before taking them from the storage area for intake or any leakage. So a designated place is made in our daycare setting, where the daily medicine, suppose in case of like a Hodgkin lymphoma, when the medicine received in the day 1 to day 5, so storage of the medicine taking place in the our daycare setting. The principle of safe administration of chemotherapy. First step is a prescription. Written prescription of the chemotherapy medicine clearly by the oncologist is on chemotherapy chart or in the booklet. Proper consent should be taken from the patient attendant, and it is the duty of the nurses to recheck these two things. Second step, the ordering chemotherapy medication. When we order the chemotherapy medicine, we clearly specify the patient name, CR number, date, drug name, strength, quantity required. Ensure right drug, right dose is ordering for the right patient. In the third step, receiving. When we receive the medicine from the patient, so check for the same patient name, quantity, dose, and expiry of the medication. Fourth is the storage and the dispensing. When we store the medication, maintain the proper temperature. Some medication need some kind of below 8 degrees centigrade, some need a room temperature, or some need a some need a 25 degrees centigrade. So it's a duty of the nurse to maintain the proper temperature of the patient. In mixing in the separate area, dispense the drug for admixing in the biosafety cabinet. Send chemo admixture from along with the drug chart. Ensure that the drug name, quantity, and dose are checking again with the drug chart and admixture from the dispensing. In the preparation, mixing of anti-neoplastic drugs shall be performed in the biosafety cabinet by the trained professional. Clean the surface of the biosafety cabinet with the chlorhexidine 2% and 70% isopropyl alcohol. Spread a disposable Malina sheet before and after the preparation. Discard towel in the hazardous drugs chemical waste container as the cytotoxic waste medicine. Minimize activity around the biosafety cabinet. Wear the full set of the personal protective equipment during the preparation. Label the prepared chemotherapy drug. It should be have patient name, CR number, POC number, drug name, dose, dilution, date, and time. And paste high alert label mentioning caution chemotherapy disposed of properly. So it's the duty of the nurses. And what is the key point during administration? A sterile gauze swab shall be wrapped around the neck of an ampoule, and no medicine should be inside in the vial. Look like names like vincristine, vinblastine, cisplatin, carboplatin, mitogenton, methotrexate. So it's very careful when we prepare the some kind look-alike name of medicine. Specific dates are written on the chemotherapy chart, like day 1, day 2, day 3, not a day 1 to day 3, especially in the ABUD or OEPA cycle. Documentation of cycle numbers, cycle 1 to 6, so 1 or 2 or 3. Calculate the BSA, creatinine, or hemoglobin level, or ANC count before each cycle. Never use the trailing zero. Trailing zero means if the medication order is in the 10 mg, so it should be clearly written in the 10 mg, not a 10.0 mg. So it's clearly visible in the our daily charts. It's clearly mentioned 10 mg. And leading zero always use, like in the especially case of the vincristine or cytarabine. So if the dose of the vincristine is a 0.5 mg, so it should be written, right like a 0.5 mg, not the 0.5 mg. It will mislead to the nurses or who prepare the chemotherapy. Dosing should be written for the each day, never the entire dose of the course. In the administration, medication shall be administered as per the physician order. Double check, independent double check should be there. Means one staff is prepared and it should be verified by the other senior staff or junior staff. Administer per medication as per the order. All medications should be administered using 6 right. Check vital sign before and after the medication. Follow high alert medication protocol. Don't forget the allergy status of the drug. If the patient have the allergy of the medication, especially in case of L-asparginate or the some other medication, so you should check the allergy status of the medication. Keep anti-anaphylactic drugs in the tray. If there is an allergic reaction, stop infusion. Notify the physician. Use infusion pump as per protocol, but do not use infusion for the highly vesicant drugs. In the chemotherapy preparation phase, there is a 3-phase pre-chemotherapy phase, during chemotherapy, and post-chemotherapy. In the pre-chemotherapy, obtain the patient height, weight, and a PSA. Verify patient name and identification. Physical assessment should be done by the nurses. Current lab values, if any lab values are not normal, you should inform to the physician or the resident doctor. Revise treatment plan, check informed consent, cannulation or hydration. Cannulation should be properly and documentation should be there. So this is the checklist in our daycare. When we administer some kind of chemotherapy to the patient, it's a new patient or the old patient, these are the checklists which should be verified by the 2 nurses in our daycare setting. This is mainly 19 topic and 19 subtopics. So before, during, and the after administration. In the venipuncture, avoid the use of established IV site that more than 24 hours. When we administer the chemotherapy, we always try that IV line should be fresh. Means there should be a clearly backflow. Choose large, smooth, and palpable vein. Avoid some site to minimize the complication, especially the joint side. Apply transparent dressing to the incision site to ensure visualization. Confirm blood return from the IV line. Observe for any sign of extravasation or infiltration. If there is any sign of extravasation or infiltration, immediately stop the infusion. In the pre-chemotherapy phase, give pre-medication for the possible side effects of chemotherapy-induced nausea and vomiting. The common side effect is the nausea and vomiting. For that, we administer the ondansetron or palinosetron or as per the physician order. So you just see the some immunogenicity of the some medication. Some medication, especially the cisplatin, cyclophosphamide, and DACAP, have the high chance of the vomiting in the moderate, low, and the minimum. So choose the antiemetic as per the protocol or as per the physician order. During the chemotherapy, perform hand hygiene or done PPE to minimize the risk for the exposure. Verify the drug's name, dose, volume, rate, and route of the administration, expiry, and the appearance and integrity of the medication. Identify patient using independent double checker. Administer chemotherapy medication as per the order. Priming IV line before the administration of the chemotherapy. Monitoring the side pain and the documentation. In the post chemotherapy phase, ongoing medication, reinforcement of previously given information to the patient attendant, and side effect management. Check vital sign, especially in the some kind of medication. Initiate or the patient have some kind of previous allergy or some kind of complication. Initiate post-chemotherapy hydration, dispose of all chemotherapy waste as per the biomedical waste management rules. Ensure accurate and timely documentation. So in our daycare setting or in our PGI, proper waste management minimize the toxic waste load, or in our daycare setting, all the cytotoxic waste, including the drugs, wrappers, vials, ampoules, we put on the bag and send to the directly to the incinerator. Handling of the patient body fluid. Safe handling precautions are recommended when handling patient body fluid for at least 48 hours. However, some chemotherapy may present longer in etc., especially in the cyclophosphamide. When we handle the patient body fluid, wear double gloves and a disposable gown when handling patient body fluid after receiving chemotherapy. Flush the toilet with the lid down after dispensing of the case excreta from a patient who has received chemotherapy. It is advisable that when patient receive the chemotherapy, toilet should be separate for the other patient. When lid is not present, cover the open toilet with a plastic bag pad to prevent the release of aerosol during the flushing. In the hospital setting, handle contaminated linen with PPE and place into a keep leak-proof container. In most institutions, all illness are handled as a contaminated by the laundry person before washing. In the major system toxicity or nursing consideration, I here mostly consider for the sick system. First is the cardiac toxicity. Cardiac toxicity associated for the some kind of chemotherapy medicine, especially the endoxifen, dactinomycin, daunorubicin, doxorubicin, and high dose of hyposamide. So when we administer the some kind of this kind of medication, verify the baseline cardiac study before the drug administration. There is a clearance for the cardiac clearance. Monitor cardiac status or report symptoms regarding tachycardia, shortness of breathing, distant neck pain, or verify the physician order if any given. In the hematopoietic toxicity, toxicity associated with the drugs, endoxin, methotrexate, and the etoposide. Especially in this case, monitor hematocrit level, absolute neutrophil count, hemoglobin count, ensure prompt administration of prescribed blood products, monitor vital sign, obtain blood culture, initiate promptly all prescribed medicine, especially the antibiotic, antifungal, ensure aseptic technique used for all nursing intervention. In the neurotoxicity, drugs associated with these toxicity, ifosfamide, vinblastine, vincristine, etoposide, high dose ITO, cytarabine, carboplatin, susplatin, and methotrexate. And the nursing responsibility for this is to monitor and report the symptom of weakness, numbness, or any tingling sensation. Also monitor and report symptom of hoarseness, jaw pain, or decrease or absent deep tendon reflex, especially in case of the jaw pain is the vincristine, or severe constipation or paralytic ileus. In the pulmonary toxicity associated with the bleomycin or busulfan chemotherapy medication. Nursing responsibility, verify the baseline respiratory function, monitor respiratory status, and report symptom of dyspnea, dry cough, or any tachypnea. In the hepatic toxicity associated with the cytarabine, L-aspargine, doxorubicin, 6-MB, and the methotrexate, especially in the methotrexate. In the hepatic toxicity, nursing consideration should be monitor the liver function test, report to the physician sign of jaundice, urine, or stool color changes. In the hypersensitivity, especially associated with the L-asparginase, bleomycin, or doxorubicin and etoposide. In the nursing responsibility, report immediately to the physician, monitor vital sign or administer medication, review the patient allergy status, monitor for symptom of any hypersensitivity. If any hypersensitivity is observed in the daycare or in the ward setting, immediately stop the infusion and inform to the physician or the resident doctor. In the extravasation, basically extravasation is the unintentional installation or leakage of a drug or substance out of blood vessel in the surrounding tissue. In case of chemotherapy, blood vessel cancer therapy, leakage of an anti-cancer drug from a blood vessel into the surrounding tissue. So this is the classification of the drugs: vesicant, non-vesicant, and the irritant. So DNA binding vesicant is include the daunorubicin, dactinomycin, doxorubicin. The non-DNA binding, vinblastine, vincalculates are come in the non-DNA binding, and the irritant, carboplatin, cisplatin, cyclophosphamide are come in the category of the irritants. So what is the basic difference between the irritant and vesicant? Basically, irritant is the agent that causes aching, tightness, phlebitis, along with pain in the injection site with or without a local inflammatory reaction. But in the vesicant, any agent that has the potential to cause the blistering or tissue necrosis when it will extravasate. So vesicant, like the vincristine, vinblastine, or vinrolobine, cause the vesicant extravasation in the vesicant. So risk factor for the extravasation: some patient-related risk factors, some drug-related, device-related, some clinical-related. So patient-related is small or fragile vein, hard sclerosis vein, limited vein availability, excessive patient movement. These are the patient-related risk factors. In the drug-related, vesicant potential drug, multiple vesicant one time, volume of the drug administration, chemical properties of the drug like the osmolarity. In the device-related, high flow pressure, long infusion period, unfavorable cannulation, or the clinical-related, untrained or unexperienced staff in the vascular access. So interruption or destruction during administration, like the means the kind of overflow of the patient. Sign and symptom of the extravasation: patient complain of burning, tingling, or pain or discomfort, evidence of swelling, edema, erythema, and leaking at the site, absence of free flow of infusion, change in infusion flow, patient complain of throat pain, loss of blood return, or change in the blood flow. These are the, if you see in your setting or in clinical area these symptoms, then immediately inform to the your senior staff or your the resident or the physician. This is the grading of the this is the grading of the extravasation. So grade 1 to 5, and as per the sign and symptom, you grade the extravasation and act according to grading of the extravasation. In the event of extravasation, if the extravasation is noticeable in the daycare setting or in the your ward area, then immediately stop the infection, leave the venous exit device in place, aspirate any residual volume, and plan as per the your hospital protocol. This is a SLAP. Stop, leave, aspirate, and plan. Preventive protocol, site of insertion, large vein in the forearm, cannulation should be avoided over joint, butterfly needle must not be used for infusion, vesicant drop for longer duration. In the procedure, after cannulation, check for the blood flow, flushing with the 5 to 10 ml of normal saline, check for sign of extravasation. This is the duty of the nurses to minimize or to eliminate the extravasation. In the clinical training, do not inject against resistance. So it's a training of the all the healthcare worker who directly or indirectly involved in the chemotherapy. It should be advisable that if you feel some kind of resistance, do not inject the injection. Management of anti-neoplastic drugs by trained professional, insertion, access, and management of central or IV line by the trained or accredited healthcare professional, and share knowledge and access to the current literature in the extravasation management. In the management, we use the warm and cold application. So vincristine, vinblastine, vinrobile, and etoposide, you use the warm compress. Doxorubicin, Dono, Epi, Ida, cisplatin, we use the cold compress. Mitocin C, possible cold compress, and mitogentral is not identified yet. In the how to apply the warm compress, topical application of warm compress, and how it works. It decreases local drug concentration, increase the blood flow, which result in the enhanced resolution of pain and reabsorption of the local swelling. How to use the warm compress? Cover a warm pack with a waterproof covering and place over the affected area. Leave for 15 to 20 minutes. No moisture should come in the contact with the patient's skin. Apply every 6 hours for next 48 hours. And follow your institutional policy as per your protocol. In the patient education, keeping the extremity still while receiving vesicant drug or eating. Report immediately if any pain, swelling, redness, discomfort observed. Measure for general management, reducing further damage. Do not rub or stress the area. Do not wear tight clothing over the area. Avoid occlusive dressing over the area. Protect the area from sunlight, direct sunlight. Rest the affected area on a pillow. Move or exercise the affected area gently. Do not use cream or lotion in affected area without consultation. So we should work in our pediatric hematology oncology setting of postgraduate institute of PGI Chandigarh. No child should die in the dawn of life due to cancer. Thank you.
Thank you, Pramod. That was very comprehensive, very, you told a lot of very important things. And I think I can see a question in the chat box. The question, that's a great question. It's an important issue. So you mentioned that infusion pumps should not be used when vesicant agents are being administered. So somebody has asked why. Can you explain that?
Yes, ma'am. Basically, ma'am, infusion pumps should not be used in the vesicant, especially in the peripheral line. When the peripheral line is used, then infusion pumps should be avoided. If the PICC line or any other chemoport is used in their setting, then we should use the infusion pump. But in the peripheral line, we should avoid infusion pump.
Why is that?
Because, ma'am, when we use the peripheral line, so there is a chance of some kind of extravasation, might be pressure or some kind of other thing. So it is advisable in the peripheral line only, not in the PICC line or in the central line or in the chemoport only.
Right. So what actually happens, what Pramod is saying is that if we are using peripheral lines, which we often do for our outpatient chemotherapy, giving only vincristine or just doxorubicin injections, then in a peripheral line, there is a lot of soft tissue around that line, and it doesn't offer adequate resistance if an infusion pump is being used. So an infusion pump would continue to administer the drug, which may be going into the subcutaneous tissue if the cannula has become misplaced. In a central line or a PIC line, it's not a big issue if you have a good connection uh, and your needle is in the right position. But in a peripheral line, you might end up with an extravasation injury by using an infusion pump. If you have to give an infusion at all, then it's better to use a dosiflow. Is that what you do, Pramod, in our daycare? If you have to give an infusion pump, it's better to use a normal saline or a Baxter bag.
Yes,
And
ma'am.
if it's a time thing, then dosiflow can be used probably.
Yes, ma'am. Yes,
So
ma'am.
that will prevent excess pressure, which an infusion pump creates. So I hope that is clarified. There is another question for you
Yes,
that this is regarding disposal of chemotherapy drugs. How is one supposed to dispose of the remaining chemotherapy drugs?
Ma'am, as per protocol, ma'am, when we use the chemotherapy medication came into two forms. One is the powder form, one is the liquid form. When the medication come in the liquid form, so we use the same day. Means on the sharing basis, patient came with the like 50 mg of the doxorubicin, and we use the 30 mg. Remaining 20 mg, we just store it and use the next patient, but we do not use the next day.
Right. So in case there is a significant, not every center will have 100 patients coming into daycare every day.
Yes, ma'am.
So there would be some people who have less number of patients. There would be a single child getting some amount of chemotherapy and half the drug is residual. What are
ma'am.
you supposed to do with the rest of the half of the vial?
Ma'am, in case of like if the medicines come in the powder form like the donorubicin, so we use the same patient and discard it immediately. We do not store in the freeze in the powder form.
How do you discard? How do you discard that? You have formulated this a 50 mg vial of doxorubicin. It's dissolved. You use 20, 25, 30 mg out of it. What
Yes,
will you
ma'am.
do with the rest of the vial?
As per the biomedical waste guideline 2016, all the chemotherapy medication without cutting, without discarding, without any burning of the needle or any IV set, any vial or any ampoule, we just put in the yellow dustbin, cover it with a double label,
Okay.
mention in the cytotoxic waste, and directly send to the incinerator.
Right.
Yes,
So
ma'am.
all of this is supposed to go to incinerator.
Yes, ma'am.
And there is some more comment that if a chemo is diluted in 500 ml, it's a continuation of the same question. That if a chemo is diluted in 500 ml NS and is stopped because of some issues, what is the protocol you are using? I am not very clear on the question. The
I think, ma'am, I think maybe, ma'am, kind of some reaction maybe occur in the between. I think.
I'm sorry, whoever has asked this question, can you please unmute and ask your question, please, for better clarity?
If we have diluted the chemotherapy drug in 500 ml NS, and because of some issues I had disconnected that drugs or patient had reaction.
Yes.
So what is the discard policy, or what is the policy you are using for that 500 ml of NS which is containing of the chemotherapy drug?
Actually, ma'am, when we administer the chemotherapy in a patient, and suppose 100 ml of some kind of chemotherapy is already given to the patient, and patient has some kind of reaction or some kind of anaphylactic reaction. So we should immediately stop the medication, inform to the resident or the our faculty. Faculty or resident came to the daycare or in our clinical setting. They assess the patient, they may be order some kind of Avil, hydrocodone, or some kind of medication, then reassess the medication. If patient is able or patient is hemodynamically stable, then we will again restart the medication. If this is not possible, then we do not preserve this medication in the fridge. We just discard this medication as other cytotoxic medication.
But it's dissolved medication. How you are just throw that NS is containing suppose 400 ml, 100 ml you had given.
Yes.
So that 400 ml you are directly throwing into the bio this thing in yellow bag, or you are just emptying that drugs.
No, directly in the yellow bag.
Okay,
As
so
per the biomedical guideline, directly in the yellow bag.
okay, thank you.
Yes, welcome.
Are there any other questions? I think it's the same question. How to discard is another question, but I think you've already covered that adequately. So I think our daycare staff and the staff everywhere plays a huge role in creating a safe environment, because it is a double check of whatever we have charted. And a nurse who is used to giving chemotherapy knows how much is the amount to be given. So a double check is always a great idea. I think somebody has asked Pramod, if
Yes.
you're giving vincristine in 100 ml, what is the question? Can you to avoid extravasation? If you are trying to give vincristine in 100 ml NS, how do you avoid extravasation? It's a continuation from the first question, I think. Would you like to expand on that?
मैम क्वेश्चन एक बार या तो डायरेक्टली पूछ सकते हैं क्वेश्चन.
So please unmute and ask the question for vincristine. I think Pramod, the question is ki, because it's usually we give vincristine in 10 ml normal saline as a slow push. But
Yes,
if
ma'am.
it has to be given as a in 100 ml NS, it's meant to go over 1 hour or 6 hours. Then
Yes,
how
ma'am.
is it to be administered to avoid extravasation? Because it's a very, very vesicant agent, as you've just shown us, and you've shown us the vincristine extravasation injury as well.
Yes,
So
ma'am.
how is one supposed to do that?
Actually, ma'am, dilution of the vincristine is avoided as much as possible. That's why we dilute the vincristine in the 10 ml or 20 ml normal saline. Because of when we dilute the medication in the large volume, like the 100 or 500 ml, so there may be a chance, especially in the pediatric population, because in the pediatric patient, the chances of the extravasation is more because of their movement. Second, their resistance to the medication. So as much as possible, we avoid the mass dilution. If you administer the vincristine in the 100 or 500 ml, if 500 ml dilution is never recommended. Yes, we administer the in the 100 ml as much as I think maximum in the 20 in our daycare setting we administer in the 20 ml normal saline or 10 ml normal saline. But we are not advised that you dilute the vincristine in the 100 ml or 500 ml normal saline. This is
Right.
not advised.
So there are, we typically give vincristine in 10 to 20 ml, as you've mentioned. There are some protocols which mention that vincristine is meant to be given over a 1 hour or even a 24-hour infusion, in which case you would definitely need to dilute it in more than 10 to 20 ml.
Yes,
So one thing from the oncology point of view is that there is head-to-head, there is no great data available, but there is no benefit, clear benefit of giving vincristine over 1 hour, 6 hour, 24 hour, or as a slow push. So most of the times the oncologists end up giving charting pushes rather than infusions over 24 hours, as is recommended in certain protocols, if that is the question. That is one. Second thing, if you do indeed have to give an infusion over a large volume of time, then it would be a better idea to have a central line, a PICC line, portacath, any other form of vascular access rather than a peripheral line, because sooner or later with repeated injections, there will be a higher risk of extravasation injury with a drug like this. So that is how you would administer. And again, if at all you have to give an infusion, you do not have any central access, then not by an infusion pump, at least we use a dosiflow meter, which helps us modulate the flow. And though we do not practically give vincristine over 24 hours at our center at all, I hope I'm audible. Somebody has typed that there is an audibility issue. I hope we are audible to other people. And somebody has raised a hand, that is Mr. Rajesh raised a hand and subsequently has typed the question. Liquid diluted injection, how many times do you store it after opening? So that is a
Storage.
question.
Storage.
Yes, of
Yes, ma'am. Basically, it's a totally depend upon the your cold chain means the storage system. First thing, if you have the some kind of proper storage system, then you store it. But injection came in the powder form, and we dilute it. We never recommend it's a storage condition, but it like kind of chemotherapy drugs who came in the liquid form. We store it, but try to it that we, use it same day. We do not store the medication after use.
right. So anything you are reconstituting, you should
Yeah.
not be storing for long periods, definitely not beyond 24 hours.
Yes, ma'am.
Then there is another question which says, can we give 50 ml NS for pediatric oncology for vincristine over 1 hour? Yes, it can be given. It depends on the weight of the child and the
Yes.
charting of vincristine. But the same caveats apply that it's an infusion, so you need to be careful with vincristine, preferably give through a central venous access rather than a peripheral
Okay.
access. There is another question. There are quite a few questions here. So for oral chemotherapy, how should we instruct to parents to give? Because they will handle like 6 MP tablet or or capsule of etoposide. How do you tell the parents to handle those tablets or capsules? Pramod, would you like to take this up?
Yes, ma'am. When we instruct or educate the patient regarding the oral, especially the oral chemotherapy medication, like the methotrexate, 6-MP, etoposide, or any other medication. So first thing, the storage. If the temperature is mentioned either 25 or 30 degrees, so patient keep these medications in the room temperature at their safe level, where the other children or other member of the family does not reach. Second thing is the dose. Like the 6-MP, 50 mg in our setting, our faculty just write the 50 mg of 6-MP, right? The 3 days full tablet and 3 days half tablet, means like the 4 days full tablet and 3 days half tablet. Then we just educate them that 4 days full tablet, and then divide the tablet into 2 parts. So we just educate about the brief about the how to take and how to store and how to take. And most common issue is that the patient taking the medication, and after that patient vomit out it. Then what to do? Sometimes patient just repeat it कि एक medication हो गया है, अभी दोबारा दे देते हैं, उसको vomit हो गया. नहीं. This is not a good.
Just a second, Pramod, I'll confirm from our host that we are both audible, because there are some messages coming in the chat box as well as the group that some people are having audibility issues. Kaina, can you please confirm that we are audible? Or anybody who, yes, somebody has typed that we are audible. Thank you so much.
Yes, you are audible.
Thank you. Thank you. Please continue, Pramod.
Yes. So, ma'am, basically issue is that ki, what type of instruction is written in the book. We just tell them patient that you should follow these protocol. If you have any problem in this, then directly meet to the some kind resident or the staff.
So, right, you're right. I think one of the concerns is very rightly, I think from the person who is typing, one of the thoughts behind this question might be that parents will also be exposed to a chemotherapeutic agent.
Yes.
So that was probably one of the concerns. So obviously, hand washing before and after is very important. And in an older child, you can try to kind of not take the tablet in the hand, but just pop the pill straight from the from the pill box or the pill container, basically.
And
That would be one.
and I also mentioned in the ma'am, PPE, single gloves, you should wear the single gloves when you use the kind of oral
Right.
chemotherapy.
So parents should wear gloves, and pregnant ladies should preferably not handle the chemotherapy at all. Like
Yes.
if they are expecting, they should not be the people giving chemotherapy to their older child.
Yes, ma'am.
So somebody has asked, specify some immediate symptoms while preparing the chemotherapy agent if you have come in contact with the drug by mistake. And another question is, how many days can we store injection ham cell?
Ham cell, right. We store the ham cell in the next 48 hours after open of the vial, 48 hours. Or in case of PEG GCSF, we use in the within 72 hours.
Right. So the instruction on ham cell says, ideally you should just look at what the instructions say. It says 24 hours actually. A lot of people store it for 2 weeks also because it's a very expensive injection, and it's difficult for the patient to buy it repeatedly. So that is not ideal. We do not know how much the efficacy lasts at 14 days. We all do these things to decrease the cost to the patient or cost to the institute. But ideally, we should be following whatever the vial vial says that and it says that we should not store it beyond 24 hours. At our institute, we store it for 1.5 to 2 days at the most, and then we discard it. So somebody has asked how long we can keep nivolumab after dilution. We do not use nivolumab in our daycare, so I do not think we would have any on-hand experience with it. But finally, all these drugs, whatever the vial says. And symptoms, I think we did you answer symptoms after coming in contact with chemotherapy agent?
Ma'am, as such data is not available, but I think some kind of uneasiness, headache, maybe, but I'm not very much sure about it.
Right. So that depends on basically what is the area which we have come in contact with. If it is a facial area or some mucosa, then there is a lot of itching and burning. If it is eyes, then you need to go immediately to the ophthalmologist. You will typically need to wash the eye, require steroid drops, probably require a close evaluation. But apart from a topical symptoms with some of the agents, there are no other immediate clear symptoms which would happen with any of these drugs.
Yes.
So another question is, if a child is getting hydroxyurea 250 mg and it is available 500 mg, how to administer? So yes, it's an issue. It's difficult to administer. One way is that we administer it alternate day if it is possible, to kind of make up the dose. It has a slightly long T half, so it's not very difficult to give it alternate day, in which case the child will be receiving 500 mg every alternate day, which basically means we'll be getting 250 mg per day over the week if we calculate. So that is one way to do it. Other ways, you open the hydroxyurea capsule, administer half of it and discard the rest half, give it like that daily. That will base 50% of the hydroxyurea, and we do not know after opening what will be the drug level available to the child. And if somebody is exposed to methotrexate drug, what should we do? Why to avoid giving tablet 6 MP with milk? Because some of the pharma studies have shown that the drug levels of 6 MP are better on empty stomach and better when it is administered in the evening. So for optimal drug levels, as it is, its absorbance is not very good. So if somebody is exposed to methotrexate drug, what should we do? I am not sure about the question. Maybe you can answer, or if you want to elaborate more on the question. What do you do if somebody is exposed to methotrexate? Probably you mean splashing with methotrexate while preparing. Whoever has asked the question, what are you supposed to do if somebody is splashed? So spill is something that will be covered in our next talk actually. So yes, the question is splash. So please attend the next session if you want to know the answer to this. So next session I'll announce here. We are already kind of finishing with our time. Next session is going to be on management of chemotherapy errors and management of spills. So that will be taken by nursing staff from Tata Memorial Hospital, Mumbai. If there are any other questions, we'll deal with them here. Otherwise, the splashing and the errors we will primarily deal with in our next session. And thank you, Pramod, for a very nice learning session today.
Thank you, ma'am.
Thank you, Pramod sir.
Thank you.
Thank you.
Thank you, everybody, for attending and for participating in the discussion today. And I look forward to having you all and having an interactive session in the month of August.
Thank you,
Goodbye,
ma'am.
everyone.
Thank you.
Bye.